Good morning. I am from Medicine 1 to present about this patient based on the title Beyond the Dewdrops. He is Mr. A driver from 1M body, presented to us with rashes all over the body, developed in 6 days, with 2-day history of fever and 1 episode of involuntary tonic movements. And further elucidating the history, his rash was first initially noted on the abdomen, then progressed to face. It formed blisters, initially produced a clear watery discharge, then forming the turbid discharge. These blisters are of varying size and are seen in groups. He also developed high-grade fever for 2 days, which was associated with chills and rigor. There was one episode of tonic involuntary movement, which involving all 4 limbs, had frothing from mouth, remained drowsy after the episode. He was taken to the nearby hospital where he got intubated and was referred here for further management. So, eliciting his contact history, there was similar illness in his family. Both of his sons developed this fever with rashes and settled. 1 week later, the patient developed similar rash. He is a known diabetic since 1 year on irregular oral medications. He is an ethanol consumer since 30 years. On examination, his vitals, he had a pulse rate of 112 per minute with a systolic BP of 200 and diastolic BP of 100 with a dispatch rate of 38. On general examination, his TCS was 3/15. We received him in an intubated state. And there was a pleomorphic rash seen over face, ears, tongue, upper and lower limbs. These were all vesicular with crust and with presence of serous discharge. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. On examination of systemic systems, his respiratory system examination revealed mild crackles over the right infrascapular area, and other systems were normal. So, syndrome complex of this patient with crops of crusted rash with seizure with decreased sensorium. We came to a clinical diagnosis of acute encephalitis with probable etiology of varicella. So, in further investigation, his counts was 11,700 with predominant neutrophilia and with hemoglobin 16.3 with significant elevation in the liver enzymes, and his HbA1c was found to be 10.6. And then we, considering his encephalitis feature, we proceeded with a MRI brain that showed a leptomeningeal and pachymeningeal enhancement with nodular enhancement in the occipital lobe, pointing towards the infective etiology. We proceeded with CSF analysis that showed elevated protein of 558 mg per deciliter with a glucose of 229, and his counts were predominantly lymphocytic, and his CSF turned positive for varicella PCR, and his culture revealed no bacterial growth. So, looking into varicella zoster as a virus, it is a human herpes virus 3 neurotropic virus seen only in humans. It spreads through inhalation and foments. It belongs to family Herpes viridae and genus varicella-virus. It is a spherical virion with a lipid envelope and glycoprotein spikes. It has icosahedral symmetry with a single linear double-stranded DNA. Epidemiology of varicella extends like primary varicella infection causes diffuse vesicular rash. Endogenous reactivation of latent varicella results in herpes zoster. It is highly contagious with a secondary attack rate of more than 90%. Transmission in susceptible host. Contact with is due to contact with aerolized droplets from the nasopharyngeal secretions of the infected individual or by direct cutaneous contact with the vesical fluid. After entering into the body, the virus undergoes localized replication. Primary viremia within the reticuloendothelial seedling, followed by secondary viremia. The incubation period of the condition is 10 to 21 days. The period of infectivity is 48 hours prior to onset of the rash. This is the maximum period of infectivity until the skin lesions are fully crusted. So, clinically, varicella can present as uncomplicated varicella and complicated varicella. Uncomplicated varicella has a prodromal phase of 24 hours with fever, malaise, pharyngitis, and loss of appetite. Then develops rash that is pruritic with successive drops, begins as macules and become papules, described characteristically as dewdrop in rose petals, and it stops generally by 4th day and gets crusted by 6th day. So, considering the complications of varicella, it may be due to the superadded bacterial infections causing soft tissue infections like cellulitis, myositis, necrotizing fasciitis, and toxic shock syndrome. can cause pneumonia, pharyngitis, otitis media. Considering a neurological complication, two distinct forms of encephalitis were identified. It may be acute cerebellar ataxia or diffuse encephalitis. The acute cerebellar ataxia is a limited time course. It generally recovers completely. The diffuse encephalitis presents with delirium, seizures, and focal neurological signs, as in our patient. Pathologically, it can cause either large vessel vasculopathy or small vessel vasculopathy or ventriculitis. The incidence of this diffuse encephalitis is 0.1% to 0.2%, with 5 to 20% of mortality, and 50% of the survivors has neurological sequelae. This is a study considering the neurological outcome of varicella encephalitis 1 year after the ICU admission. It is a multi-center cohort study in which after 1 year follow-up of the varicella encephalitis patients had showed 33% of the patient had seizures and 33% has chronic headache, others having nerve deficits, ataxia, 75% had persistent abnormal EEG, and 30% developed CNS vasculitis. One another study studying the cerebrovascular complications after adult onset varicella zoster documented ischemic stroke, hemorrhagic stroke. The lesions noted in these patients in their MRI did not occur with the characteristics of cerebrovascular events by atherosclerosis, and some developed cortical vein thrombosis. So treatment of this condition is acyclovir intravenous 15 mg per kg every 8 hours for 14 days and anti-epileptics. So in our patient, he was started with acyclovir for 14 days and he was clinically improved. During the stay in the ICU, he developed a ventilator-associated pneumonia and received polymyxin. He also developed hyperthermia associated with encephalitis. His core body temperature when we received him was 108 degrees Celsius. He was corrected with cold saline infusion, ice pack applications, and cold water spray. He also developed gram-negative sepsis with ralstonia and was given minocycline. On day 5 of admission, he got extubated. Throughout the hospital stay, no further seizure episodes occurred. He got discharged on day 14 in a stable state. His anti-diabetic drugs were optimized. So take-home points is, this is a clinical presentation in which adult obtaining varicella with severe complications, and large proportion of CNS varicella have long-term sequelae. Thank you.
Thank you. Are there any, did you come across any, so you said large proportion of them have long-term complications, but your patient improved completely well, although he came significantly moribund. So any reasons for that? Did you come across any prognostic features in your when you were reading?
Two things were mentioned in the text and articles. One is age of the patient, more than 60 years, and the underlying immunocompetency state. Both will decide the long-term
severity of the
severity.
Long-term. Okay, thanks. Thank you. Who's next? Yeah.
So I